Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Calhoun Cunningham.
Thank you, Mandy. And let me also say welcome and thank you for coming out tonight to this evening's Healthy Focus session. Tonight I'd like to talk a little bit about some of the upcoming or current trends in treating hearing loss, but also what the future holds and what will be around the corner. To give you a little bit of additional background information about myself, my primary training is as an ear, nose, and throat physician or otolaryngologist, but in addition to that, I did 2 extra years of training just in what's known as otology and neurotology. So this is the field that specializes just in ear-related disorders or disorders involving the hearing and balance nerves. And so in my practice, it's pretty much limited to just hearing and balance type of issues rather than the whole spectrum of ear, nose, and throat. And so to move forward, how common is hearing loss and how much of a problem is this? Well, it's actually the third most common problem that affects healthcare or for that patients go to see their healthcare provider for. About 36 million U.S. adults, or 17%, have some form of hearing loss. And hearing loss increases with age. If you look in the age range between 45 and 64 years, about 18% of adults are affected by hearing loss. That increases to 30% in the 65 to 75 range, and then 47% of patients older than 75 will have some form of hearing loss. Untreated hearing loss costs the economy about $56 billion in lost productivity each year. And of greater importance is there's been a really sharp rise in hearing loss in young people nowadays. And we believe a lot of this is due to industrial noise, but also the advent of things like iPods and music. What are the causes of hearing loss? Hearing loss can really be broken down into 2 main causes: conductive hearing loss and sensory neural hearing loss, or you can have a combination of both of these, which is known as mixed hearing loss. And so before we get into that, just to look at basically how the ear works and how we hear, the ear is really divided up into 3 main parts. We have the outer ear, which consists of the auricle and the earlobe and the ear canal. And so it extends from the opening of the ear to the ear drum itself. And this is actually a pretty important part of our hearing. We have the outer ear. The pinna is large because it actually serves the role of capturing sound and then funneling it into the ear canal. And then there are certain properties about the shape of the outer ear itself that helps us amplify certain frequencies, and in particular some of the higher frequencies. The middle ear is made up of the eardrum and then the middle hearing bones. And so from the eardrum to what's known as the inner ear, this is called the middle ear space. And this is an air-containing space. And it actually connects to the back of the nose through the eustachian tube. So whenever you go in the mountains or up in an airplane and your ears are popping, it's because there's air coming up or coming out of this eustachian tube in order to equalize the pressure in here. In order for the eardrum to vibrate when sound hits it, you have to have air on both sides. There are 3 middle ear hearing bones: the malleus or the hammer, the incus or anvil, or the stapes, also known as the stirrup. They serve a role of taking sound from the eardrum and channeling it into the inner ear. And it's actually a lever mechanism. And there is a slight amount of sound amplification through those hearing bones by the way that they function. This is a picture. This is what the normal eardrum looks like looking down through the ear canal. And as you can see, it's sort of a clear or translucent membrane. This is the first hearing bone coming down, which is the malleus. You can see here. The head of the malleus is up above, though, the eardrum, behind this wall of bone. So it would be extending up like this, and you really can't see that. This round central portion is known as the umbo, and that's where the eardrum actually attaches to the first hearing bone. And the eardrum's not flat. It's actually shaped like a cone so that when sound hits it, it's sort of funneled down towards the tip of the malleus, and that helps increase the amount of vibration of those hearing bones. And then finally, we have the inner ear, which is all the nerve function of the ear. And the inner ear, or the labyrinth, that's the other name of it, is made up of the cochlea, which contains all of the actual hearing or sensory nerves. And then the other part is the balance portion. And these are the balance canals, also known as the semicircular canals. And there are 3 of those canals. And so whenever someone has problems with balance and they talk about inner ear problems, it's a problem with the balance portion here, or these canals. Within the cochlea, you can see that this is it's actually a duct that coils around itself. And this picture is, unfortunately, it's a little bit inaccurate. In the human inner ear, there are 2.5 turns of the cochlea, and here that we're seeing more than that. But this is an actual histologic microscopic section of the inner ear, and this is called the cochlear duct, and we can see how it coils around. And you can actually see the individual nerve fibers coming out here. And these nerve fibers go to what's known as hair cells. And those are when people talk about the hairs in their inner ear or hair cell loss, it's because these little nerves and these little hair cells will start to degenerate over time. They're lined up in an orderly fashion, going from high frequency nerves to low frequency as we go around the turns here. So it's almost like a piano keyboard that has been rolled up on itself, and we're going from the high keys to the low keys as we go around here. And so when sound comes into the ear canal, it hits the eardrum, vibrating the eardrum, it travels through these 3 hearing bones and then into the cochlear duct, where the vibrations are picked up by those small hair cells. Now the way the sound gets in here, this duct here is filled with fluid, and the stapes bone acts like a piston vibrating, and it vibrates that fluid, and that's how sound vibrations get transferred through. So whenever someone comes in for evaluation of hearing loss, we have to first determine, well, where is the problem? So, because there can be issues with any of these 3 areas. Conductive hearing loss is a problem getting the sound into the inner ear where the nerves are. And these are usually simple problems most of the time to fix. And this can be anything from just having wax in the ear canal that's blocking the ear canal. You can have a foreign body. This is a small bead or a marble that a child probably put into their ear. A more common problem is middle ear fluid. So aside from the actual ear canal, you can have problems in the middle ear space. Children who get a lot of ear infections, or patients who do have problems with the eustachian tube, tend to get fluid that accumulates through here. This is a picture of the eardrum, and you can kind of see this golden or amber colored fluid. There's a little air bubble right here behind the eardrum. This is sterile fluid. It's not necessarily an infection, but with all the fluid behind the eardrum, it can't vibrate the way it's supposed to. And then, of course, there are other problems. This is a hole in the eardrum, and when that happens, you don't have the surface area of the eardrum remaining to collect the sound, and so that causes a conductive hearing loss. Or there can be problems with one of the 3 hearing bones. Otosclerosis is an inherited problem in which a bony plaque forms around the stapes bone and prevents it from vibrating. So when we talk about conductive hearing loss, it's not a problem with the nerves. The nerves are okay. We can't get the sound through here into where the nerves are. Now, by far and away, the most common type of hearing loss that's seen is sensory neural hearing loss. And if you took everyone who came in to see the doctor for hearing loss, this makes up about 90% of those patients. And this is a problem with actual degeneration of the hearing nerve. And again, here's that picture, that nice picture we see of the cochlea, and we see the individual nerve fibers here. And in this picture, again, you can see the actual individual nerve fibers, and then you hit this region right here where there are no nerve fibers. And this is a picture of someone who's had noise trauma to the ear, which typically affects about the 4,000 hertz frequency range. And as you can see, the nerve fibers have been damaged or knocked out in this range. There are various causes of nerve hearing loss. Probably the most common cause is presbycusis, which is also known as age-related hearing loss. So just like everything else, as we get older, those small nerves in the inner ear start to degenerate. And this can start to happen when we're in our 30s. There are hereditary types of hearing loss, so genetic causes where certain families, a patient may start developing hearing loss in their 20s or 30s, and then it rapidly progresses to deafness, or it may just be a very slow change over time. Age-related hearing loss, presbycusis, typically starts probably when we're in our anywhere between our 40s and 60s. Noise trauma, as we mentioned, is a common cause of hearing loss, especially nowadays with all the industrial noise we're exposed to. And then, of course, infections are a common cause of nerve hearing loss, either chronic recurring ear infections, or patients may have just a sudden hearing loss where just overnight the hearing goes out completely in one ear, and that can be due to a virus that affects the inner ear. This is a graph which sort of depicts what happens with age-related hearing loss, and as you can see here, these numbers represent the amount in decibels of hearing loss. And so we're going from no hearing loss, no decibels of hearing loss, to about 40 decibels of hearing loss. This is the frequency range that we can hear across. Most commonly about 125 hertz. This is a kind of a bass sound, is on the low end of the frequency range, and usually we can hear to about maybe 16,000 hertz. But as you can see, a 20-year-old is going to have no hearing loss. But when we start to get in our 30s, we start to see a little decline here. In our 40s, more, 50s, and then in our 60s. And then, of course, mixed hearing loss would be someone who has a combination of both of these. So, for example, someone who's had lots of ear infections or has had a trauma to the ear, they may have damage to the eardrum or the hearing bones, but on top of that, they also have nerve hearing loss. So how do we diagnose which type it is? It usually comes down to a basic audiologic evaluation or an audiogram. And this picture is showing how this is done. This is a sound booth where a patient is placed in this booth and they're completely isolated from any sound whatsoever. It's almost like sitting in a vacuum. The audiologist sits on outside of the booth on the other side, and either headphones or actual inserts are placed into the ear canal, and various tones are played, and then the patient pushes a button every time they hear the sound. We do several tests when we do the hearing test. One is known as pure tone audiometry, and this is just detecting whether or not you can hear a sound. And we do it by testing air conduction, which is placing the sound in the ear canal. But we also do it by what's known as bone conduction. So with bone conduction, rather than putting a speaker in the ear canal, we place a stimulator on the bone behind the ear. And that stimulator vibrates the bone of the skull, and at a level of 0 decibels, so almost minimal sound whatsoever, sound will penetrate the skull and go directly into the inner ear. The reason for this is by testing the bone and comparing it with the air, we can tell if there is a conductive hearing loss, a problem with the eardrum, or one of those 3 hearing bones. And then the other important part of the hearing test is what's known as word recognition. So hearing isn't just about being able to detect sounds, it's also about being able to understand what you're hearing or how clear things sound. And with the word recognition test, the patient is given a list of words, monosyllable words, and they're asked to repeat those. And the words are spoken at a very comfortable hearing level. And then we record the percentage correct. And so this is sort of the graph. This is what an audiogram test looks like. If you can hear, and the way we look at these, we're testing each one of these frequencies from about 250 hertz to 8,000. And we're going from bass sounds or low frequency sounds to high frequency sounds. And then up and down, we record the volume level, how loud we had to play it in order for you to hear it. If you can hear a sound played between 0 and 25, that's considered normal hearing. Once the sound has to be turned up above 25 decibels, we start getting into hearing loss. So between 25 and 40 is considered mild, 40 and 55 moderate, 55 and 70 is moderately severe, 70 and 90 decibels is a severe hearing loss, and if it's above 90, that's considered profound hearing loss. And this is what it looks like. And so the yellow represents the left ear, the red is the right. Each circle represents a different frequency we tested. As you can see, the hearing is normal through here, but in the right ear, there's a sudden drop here in the higher frequencies, 4,006 and 8,000 hertz. And then we record the word recognition. For example, 70, and using the right ear and listening to words, this individual only got 76% correct. In the left ear, they scored 100% correct. This is important because in order for hearing to be usable, to understand speech and what someone is saying, you have to be able to get about 50% of these correct. Once you go below 50%, you reach a point where even though someone's speaking and you can hear something being spoken, you can't make out what's being said very well. This is a common sheet that's given out often to patients. It's called the audiogram of familiar sounds. And basically it just shows, because people always look at the audiogram and they say, well, where my hearing loss is at 4,000 hertz, what kind of sound is that? Well, birds chirping, that would be a frequency of around 4,000 to 8,000 hertz, and it comes in at a level of about 5 decibels, so a very soft sound. Whereas a jet airplane is also a high frequency sound, but it's at 120 decibels, so extremely loud. You'll notice most of the vowel and consonant sounds in spoken speech fall in the range right up between 250 and about 3,000 hertz. There's some that are a little bit higher, but this is known as the speech frequency range, and this is where it's most important to be able to hear. You want to be able to hear frequencies between 250 and about 3,000. So some people will have completely normal hearing through here, but when they get to 6,000 and 8,000, they have a sharp drop. And in general, they won't really notice too much of a problem because they're still hearing speech very well. So how do you know if you have hearing loss? Well, you may feel like people often mumble when they're speaking to you. You may frequently have to ask people to repeat themselves. You may misunderstand numbers or words, or believe someone is saying something different from what they are. People often, one of the key signs is the radio or the television often becomes louder. And in particular, you go to that noisy restaurant or a noisy conference room, and all of a sudden you really can't make out what's being said. Fortunately, there is help available for most types of hearing loss, and nowadays pretty much any type of hearing loss. Conductive hearing losses, again, those are usually problems getting the sound into the inner ear where it needs to be. Those can often be treated surgically or corrected. Sensory neural hearing loss, which is hearing loss due to the hearing nerve not functioning, is a little more challenging. And historically, hearing aids have been the only thing that will help with that type of hearing loss. But what we're going to talk about a little bit more tonight is some of the possible surgical treatments that are available. So what is new? Well, fortunately, we've moved well beyond these apparatuses, but this is kind of gives you an idea of what's been developed over the years. These are ear trumpets. And the odd thing is they actually work really, really well. There's a little controversy more and more coming about analog versus digital hearing aids. And as it turns out, the way the inner ear functions, it actually functions more on an analog model than it does a digital model. And so a lot of these devices, because they're just taking normal everyday sounds and amplifying them by use of a large cone or filter, the hearing a lot of times is actually better than with a digital type device, but obviously no one wants to walk around with one of these things. So hearing aids, of course, have changed quite a bit over the years. And the big change in the past 15 years is, in fact, the advent of digital technology. They range in a wide variety of shapes and sizes, from behind-the-ear type hearing aids, which historically people have always avoided these because they were quite big and cumbersome, and if you were wearing it, everyone could tell you were wearing a hearing aid. But there are some newer ones that we'll see in a few moments that have become much less conspicuous. Then there are in-the-ear style hearing aids, which actually sit right in the outer canal, as you can see. And then these are called completely in the canal. Very small hearing aids that go down into the ear canal and have a small item that you can grasp in order to remove it. This is called a receiver in the ear hearing aid. And basically, this is what's known as an open fit hearing mold. And there's an actual microphone attached way down in here. And the sound coming into the ear is picked up here, goes back through the circuitry of the hearing aid, is amplified, and then comes back through and is emitted through the speaker. It's an open fit because this is like a ring, and you can see there are little gaps here. It doesn't completely close off your ear canal, so it does allow you to hear certain sounds and frequencies the way they normally should. The tubing for these hearing aids is very small, and as you can see, you almost can't even tell if someone's wearing them. And they're very small, fitting behind the ear. And this is probably one of the, in the past 5-7 years, one of the newer things that has come out with hearing aids. They're very helpful for people who have normal hearing in the low and mid frequencies, but then they have a very sharp drop-off in their hearing in the higher frequencies. So why do some people not like their hearing aids? Well, when you put something in the ear canal that blocks your ear, whenever you speak, your own voice is going to sound louder to you. And so this is called a barrel effect. Of course, whistling or feedback, probably one of the biggest reasons people don't like hearing aids. That you may know someone who's tried hearing aids and they don't like them. Things just may not sound quite right. They're either too loud or too soft. And of course, you're always having to mess with the hearing aid. Take it in, take it out, change the batteries. So the future, of course, what everyone is really working towards is the development of more implantable hearing aids. that are not obvious, they're not on the outside, and provide better hearing. The benefit of a lot of these devices is since there isn't anything in the ear canal, you don't have this barrel or occlusion effect in the ear. The sound quality is often much better. You don't have the problems with feedback because there's not a device sitting in the ear canal. And what we'll talk about in a little bit is you get a little bit better hearing in the higher frequencies. The problem with current hearing aids is that they don't do much for hearing loss above about 3,000 to 4,000 hertz. And there are still some sounds in that frequency range that are important to be able to hear. In order to amplify frequencies higher than that, you have to turn the volume up more. And because the hearing aid sits in the ear canal, that loud sound starts to reverberate in the ear canal itself. And then the sound becomes distorted, but it also increases the chance that you'll get feedback. As the sound gets so loud, you start to get some escape of sound around the hearing aid itself, and it feeds back in through the hearing aid and is amplified. And that's what causes the annoying whistling sound. When we talk about implantable hearing devices, they can be either partially implantable or they can be totally implantable. These devices use technology known as active middle ear implants. And the three that we're going to look at, the MED-EL, SoundBridge, Otologics, and the Ototronics, utilize this technology. The MED-EL and Ototronics are currently the only two that are FDA approved in the United States. The Otologics device that we'll get to is under FDA trials currently. So this is what's known as the MED-EL Vibrant Sound Bridge. And this is the oldest one of these that's been commercially available and has sort of the longest track record. And it first came out in 1996 by a company known as Symphonics Devices, which was later purchased by MED-EL Corporation. Now, MED-EL Corporation makes cochlear implants, and so they're very interested in these types of devices. And this is what the device looks like. This is the actual the sound processor part of the device, and this is surgically implanted underneath the scalp behind the ear. An opening has to be made surgically in the mastoid bone behind the ear, and then this cable is sort of fed through the mastoid, and on the end, it's hard to tell in this picture, but you've got a little drum like this with a clip. And this drum is what's known as a floating mass transducer. Basically, it's a can that has a magnet in the inside that sort of floats in here. And then you can see this is copper wire that surrounds it. And by changing the current through this wire, it will drive this magnet back and forth like a piston so that it vibrates. And you can change the frequencies at which this canister is vibrating, and that's what the sound processor does. So this little clip is actually clipped onto the incus bone between your incus and your stapes. So when it vibrates, it's vibrating the hearing bones in the normal direction that they would vibrate in, and it amplifies the amount of vibration through those hearing bones. Now, with this device, though, even though this is all implanted under the skin, you still wear a small, basically it's the microphone and receiver here that has a battery, and with a magnet, it sits right on top of the sound processor. And this is sort of where it goes behind the ear. And if your hair is a little bit longer, you know, you can hide it a little bit. But this can be taken off very easily just with a magnet. How this differs from a conventional hearing aid, this is the conventional hearing aid. So we have actual sound that comes into the hearing aid. It's converted into an electric signal. The electric signal and a digital signal at that signal is then amplified, and then it has to be converted back to sound, an amplified sound. And so you have an amplified sound that hits the normal eardrum, goes through the hearing bones and into the inner ear. With implantable hearing devices that use this technology, active middle ear implants, you're not using any acoustic energy in the ear canal. So there's nothing in here. It's basically electromagnetic energy that drives this little can and vibrates the stapes and sends the sound into the inner ear. And this is beneficial because it does allow us to be able to amplify sounds at higher frequencies. So you can hear sounds better over a wider frequency range. And this this describes what this looks like surgically. This would be a right ear, so the ear canal would be sitting right here. And when it's done, an incision has to be made behind the ear, and the ear is actually turned forward. This area here is known as the mastoid bone. This is this hard bone you feel behind the ear. This is the opening. This is called a mastoidectomy. And then a very small opening is made going from the mastoid side to the middle ear side. And this is a magnified view looking through that opening. You can see the incus bone coming down here like a handle, and then this is the stapes bone, and they attach at about a right angle. And then this is actually, this little clip is crimped onto the incus bone. And then you can see the actual can here and the electrode wire coming off of it. And then this is the implant placed behind the mastoid. And when the incision is closed, all of this is underneath the skin. And so the other benefit of this device is, what about patients who've had problems with chronic ear infections, or they've had trauma where the eardrum has been damaged, or maybe there are no hearing bones whatsoever? As we looked at the ear earlier, I mentioned sound comes through the hearing bones, through the stapes, and into the inner ear. There's another opening here called the round window membrane, which as the stapes pushes in, this area is connected to the same duct, it bulges out. So this is actually another window or area where sound can get into the ear. If the bones are damaged or destroyed, this little transducer can actually be placed in the area of this membrane and send sound in this way, and the ear works the same either way. Or if the stapes has been damaged or removed, you can actually place this right on top of the footplate area of the stapes. So the benefit of this technology is it's even useful in patients who maybe don't have an eardrum, or they don't have the hearing bones. What are the advantages to this technology? Well, you get significant improvement in the quality of sound and speech. You have nothing in the ear canal, so the ear is open. You don't have that feeling of something being stuck in there. People who have used this state that the comfort with the device is significantly better, because basically all you have is a small receiver back behind the ear. This device has been out the longest, so it does have a pretty good track record with regard to reliability. And then, of course, you can benefit from changes in technology. Software is used to program the actual hearing levels with the device, and you can update that software. So down the road, as new things come out, it is possible to change the programming or the software. The disadvantages, and these are important. One, it is a surgical procedure. It's an outpatient surgery, and it probably takes about an hour and a half to 2 hours to perform. But probably the most important thing is cost. Unfortunately, right now, with most of these implantable hearing devices, insurance companies do not cover those costs unless there is some medical reason that a patient can't wear a conventional hearing aid. And the cost of the devices is quite high. And just to give you an idea, it ranges probably around $20,000 or more. And so, as you can see, there are not too many people who are currently using these. This is also a big problem with the technology. A lot of these companies, there have been many companies similar to this that have come out with devices over the year, but if they can't sell their product, most of them end up going bankrupt, and that unfortunately is happening. In other countries in Europe and even in Canada, even though healthcare is controlled a lot more, they do have a little more free reign with using these devices, and so in those places, more and more people are starting to benefit from it. Who is a candidate? Who would benefit from this? Well, one of the things you have to be with regard to your hearing, you have to be a candidate. This is called this audiogram is sort of what's known as a fitting guide. You have these for all hearing devices, including hearing aids. And this blue area just shows what type of hearing loss a person can have to benefit from the device. So in the low frequencies, you can have a hearing loss as low as 65 decibels. And as you go into the higher frequencies, it can be as low as 80 decibels. And you would still benefit from this type of hearing device. Once you get below this, however, it's not recommended, as it probably will not provide as much benefit. In addition, you have to have stable hearing. There are some conditions that cause hearing loss, which causes the hearing to fluctuate up and down. And so something like that is not good with these types of devices, because you constantly be having to have it reprogrammed. And of course, it's important to be free of ear infections. You may have had infections in the past, but as long as they're clear, you can have the device. But if you're currently having infections, you don't want to put an implant like this in there, because there's a high chance it could get infected. And also, they want you to have previous experience with hearing aids. This is the Otolaryngology device, which is very similar. This currently is not FDA approved in the United States, but it's under clinical trials right now. It previously was under trials, and they had some issues with the way that the device was mounted and put in the ear. Very similar to the other device, but rather than clipping something onto the stapes, this transducer is actually attached to the incus bone here. So the vibrations are actually transferred through the incus bone into the stapes. But very similar in that you wear an external sound receiver that captures the sound. This can be taken on and off with a magnet. Now moving on to the Otolaryngology Maxim. This is the other FDA partially implantable device. This is marketed for patients who have moderate to severe sensory neural hearing loss. So patients with more significant hearing loss that don't benefit from conventional hearing aids. It is only approved for adults aged 18 years or older. And again, with most of these devices, you have to be free of ear infections or middle ear problems. And this gives you an idea of who benefits from this Maxim device. Again, this is the audiogram. 25 decibels is normal, so 25 or above, this is considered normal hearing. Once we drop below 25 decibels, we're getting into hearing loss. So conventional hearing aids are pretty good for mild to moderate types of hearing loss. They're often, still we use hearing aids for moderate and even severe hearing loss, but they usually have to be behind the ear type hearing aids because they need to be more powerful. This particular device is sort of aimed at patients who fall in this range of moderate to severe hearing loss. And then, of course, if you're profoundly hearing impaired, you're a candidate for a cochlear implant, which we'll get into a little bit later. This particular device is very similar to the Meadow in that it places this small canister onto the incus and stapes, but it's not driven electrically with current. It's actually a magnet, and using electromagnetic energy, it causes this to vibrate. There are two configurations that this can be used with. One is an in the canal type hearing aid, and this is the hearing aid portion, and then it has a tubing with a stimulator that fits very deep into the ear canal, and it has to be pretty close to the tympanic membrane because, again, it's using electromagnetic energy to drive this. This is the behind the ear configuration. It's a very small tubing that goes into the ear canal, and again, it seats way down in there, very close to the eardrum. And basically, the way it works, sound energy is picked up by the actual sound receiver, and it's converted into electromagnetic energy. This energy then drives this small magnet that's attached to the incus and stapes bone. And the benefit of this is that it allows you to significantly increase the amplification without getting the distortion in the sound, because it's not being driven by actual sound, it's being driven by electromagnetic energy. With the behind the ear configuration, the other nice thing is you don't feel like you've got something, even though there's something in the ear canal, you don't feel like there's something blocking the entire ear. And this gives you an idea. This is a patient unaided, so without the hearing aid, this is their hearing loss. In the low frequencies, sound has to be turned up to about 60 decibels, which is sort of in the moderately severe range. And as you get into these higher frequencies, their hearing continues to drop, and this is a severe to profound type hearing loss here. With this Maxim hearing aid, it's bringing that hearing level back up into this range, which is mild in the low frequencies and more moderate in the higher frequencies. So it's not perfect, but it is a very significant improvement in the hearing ability. This just demonstrates a comparison of Maxim users compared to conventional hearing aids with regard to the occlusion effect. Most report significant improvement, sound quality significantly improved, less feedback, and overall satisfaction. This is a minimally invasive procedure. It's very simple and it's safe. It does require being done in either an operating room or a minor procedure type room. It involves what's known as a transcanal approach. So placing that little magnet on the hearing bones is actually done through the ear canal by making small incisions and lifting up the eardrum and then placing it there. It can be done just with local anesthetic, and it takes about 30 minutes to perform. Moving on now to fully implantable devices, this is where most people have been really interested in, and a lot of the research and technology is moving towards right now. Currently in the U.S., there is only one FDA-approved device, and that's known as the Envoy Esteem. It's relatively new. It just completed its clinical trials, but it is now available. You do have to go to certain centers in order to have this done where the staff have been trained to do it. There is another device I'll mention briefly called the Otolaryngology Carina. It's available in Europe, but it's still in clinical trials in the U.S. right now. This device is fully implantable. There is absolutely nothing on the outside or in the ear canal, and it uses your own eardrum as the actual microphone. It has a built-in battery which lasts about 5 to 9 years. It is indicated only for adults. One of the important things about this is you have to have normal middle ear structures. So you can't have had any sort of damage to the middle ear hearing bones or any major problems with the eardrum. And you can't currently be having ongoing ear infections. They do recommend that patients first try conventional hearing aids before considering this. And this is what the device looks like. Very similar to the others we've seen. This is the sound processor, which is implanted under the scalp behind the ear. And then we have actually 2 leads coming off of here. One of these is a sensor, and this is actually placed on the incus bone or right at the head of the malleus bone. So when normal sound comes into the ear canal, it vibrates the eardrum. The hearing bones vibrate the way they normally would, and this sensor detects those vibrations and sends a signal back to the sound processor. That sound processor can register the frequency of those vibrations and then amplify the vibrations and send a signal back to the driver. This driver is attached to the stapes bone and actually vibrates the stapes bone at a higher amplitude or amplification and sends the sound into the inner ear. It does require surgery, and it requires doing a mastoidectomy behind the ear. The one downside, and where this has received some criticism, is that in order to place this little driver on the stapes, you have to separate the hearing bones here. And they can, if something were to be to happen and it had to be removed, you can repair those using some cement. But a lot of people argue that you should never damage a normal set of hearing bones. Once the device is in place, an audiologist actually programs the device according to the frequencies where you have hearing loss. And then the patient uses a personal programmer that adjusts the volume levels or the clarity or the certain listening situations that you're in. So far, recipients of this device have been extremely pleased with the way things sound and the hearing that's received from it. The downside is technically placing it is fairly complicated, and there have been some issues with getting it placed just right. I think one problem we may see is that down the road, the longer people use these, we may start to see some issues with having all of these transducers and sensors in the middle ear. But so far, the results have been very good, and it has been approved by the FDA as a safe and effective device. This is the Otolaryngology Carina device, very similar to the other one. This currently is not approved in the U.S., but is approved in Europe. It is undergoing trials currently in the U.S. The difference between this device is that rather than having a sensor near the eardrum or on these hearing bones, it actually has a microphone that sits under the skin. And this is where a lot of technology is going right now. They've developed these microphones that you can place under the scalp that can pick up sounds through the skin and then amplify those with the hearing aid. The actual transducer or driver part then attaches to the incus bone to send the sound into the cochlea. One of the problems with having the microphone here is that there are some unexpected things you don't think about, such as chewing and all the muscle movement that you have up here. And so early on when they were developing these, people were trying them and they were getting so much background noise from the sound of the muscles moving that they had to change things. And now they use technology to kind of, in the sound processor, to dampen or filter out those sounds. So implantable hearing devices, what are some of the considerations? Well, as I mentioned, the cost of the device is probably the biggest problem right now. Until we can make these devices so that they're smaller and more cost-effective, not that many people are going to end up using them. They do require a surgical procedure, and often that may involve general anesthesia. There's always a risk of device failure. Nothing that man makes is completely foolproof. And so there's always a chance that there could be a failure of the device or something going on with the circuitry. One of the big things to think about is these devices all utilize either a magnet or some form of metal circuitry within them. And so if you have conditions which require MRIs, or there may be an issue where you need to have an MRI, you may not be able to have an MRI scan with these devices. MRIs stand for magnetic resonance imaging. Rather than using conventional X-rays, they use a large magnet in order to capture images of the body. And so that also is something that has to be taken into consideration. Now I'd like to talk a little bit about just some special devices, some interesting things that will be coming out, and some things that we currently have that use other means of getting sound into the ear. This is called the ear lens. Now this is not out yet, but this is fairly new technology that probably will come out in the next couple of years that may make a big change in the way hearing devices are used. This is sort of marketed, or they will market it as the contact lens for hearing. And this is what it looks like. This is a standard contact lens. This is what the ear lens looks like. And this is actually not new technology. It's been around for a while. When it was originally created, this small lens was placed on the eardrum, and this was a magnet that was centered right over the center of the first hearing bone. And the original device you had to wear a behind-the-ear type hearing device. This small tubing went into the ear canal, and the tubing has a microphone here to detect sound, and then it had a driver that used electromagnetic energy to vibrate this magnet. Well, the ear lens that they're working on now actually uses light energy to drive a photoreceptor on this lens here. And so one of the benefits of this, of having this microphone in the ear canal, is you can take advantage of the normal acoustic properties of the ear, the way the outer ear captures sound, the way sound resonates in the ear canal. Because the sound is actually detected, rather than being detected outside of the ear, it's detected within the ear canal itself. And the sound feeds back from the microphone through the processor, then is sent back out to this driver to stimulate the actual ear lens. And so with the way the photoreceptor works, sound is actually encoded into one or more wavelengths of light. This light then strikes a photodiode or utilizes a photodiode that converts light energy into an actual electric voltage. The voltage then drives an electromagnet which drives the eardrum. This is one variation of it. To give you an idea of how this compares to conventional hearing aids, this is the frequency range that the human ear can hear from, going from 20 hertz up to 20 kilohertz. And again, normal everyday sounds are falling in the range between about 250 hertz to 3,000 or 4,000 hertz. And so someone with perfect hearing can hear all of these frequencies. A conventional hearing aid that sits in the ear canal is really pretty good for amplifying sounds between 100 hertz and about 4,000 hertz. The open fit style hearing aid, as I mentioned, it's more for improving some of the higher frequency hearing between 1,000 and about 4,000 hertz. The ear lens, the benefit of it is that it can help increase hearing over a wider frequency range, so from about 100 hertz to about 10 kilohertz here. And again, the reason for that is it's not using sound or acoustic energy. It's using, in this case, either electromagnetic energy or light energy to actually vibrate the eardrum. Unfortunately, it's not currently FDA approved. It is in clinical trials, and so hopefully within the next couple of years, it will be coming out. One of the other benefits that is sort of touted with this device is that it significantly improves your discrimination in noisy environments or background noise. Now, what about, moving on to sort of a different scenario, what about patients who have unilateral hearing loss? So they have normal hearing in one ear but no hearing in the other ear. This can happen from a variety of reasons. It may be due to ear infections, noise trauma to one ear. Meniere's disease is a condition which also often causes hearing loss in one ear. Tumors, or it can be something a patient is born with. This does present a fairly significant problem because obviously it's difficult hearing on the side that you're deaf, and every time someone's sitting on that side or trying to speak to you from that side, you're not able to understand what they're hearing. And there's constantly that act of turning your ear to try to hear. In addition, you have to have equal hearing in both ears in order to determine what direction sound is coming from. The brain is so good it can detect the timing difference that sound arrives at one ear and compare it to how long it takes to get to the ear on the other side. And that's how we determine where sound is coming from. So if you're deaf in one ear, there's no reference to compare the sound to, and you can't determine what direction sound is coming from. It also makes it much more difficult to hear in background noise. The head shadow effect, again, that's the effect where if you're deaf in the right ear, your head is actually getting in the way of sound coming around and getting into your left ear. And so there are options for situations where there's hearing loss in only one ear. Historically, what's been used is something known as a cross hearing aid, which stands for contralateral routing of signal. And basically what this is you wear a hearing aid in both ears. If you're deaf in the right ear, you wear a receiver that basically just picks up sound, and then it transfers it over to a speaker in your left ear. So it just allows you to hear the sounds coming from the right side, but you're still hearing everything in your right ear, in your left ear. These work okay, but the sound quality is not always not that great, and a lot of people don't like having to now wear a hearing aid in their good ear. In my experience, patients who are in meeting situations where they're constantly listening to people on both sides, they do benefit, and although it's not perfect, they'll use them. But for everyday use, just going out and about, most patients don't find that it makes that big of a difference. The other option is surgical options using something known as bone-anchored hearing aids. And currently there are two of these. One is made by Cochlea Corporation called a Baha, which is where this name comes from, bone-anchored hearing aid. Oticon Corporation, who makes hearing aids, has also created a similar device known as the Ponto. This is what the Baha basically consists of. And really, it's just a small screw that's implanted into the bone behind the ear. And then this is known as the abutment, which fits into this screw. And this abutment is a permanent fixture. I mean, it comes through the skin, and it's like a button that permanently sits there. You attach a sound processor, which is basically a hearing aid, onto this abutment. And what it basically does is the sound processor picks up sound, amplifies it, and transfers sound through the bone. Now, sound, as I mentioned earlier, the bone is dense enough in the skull that sound will travel through the bone at a level of about 0 decibels. And so it doesn't take much volume at all for sound, if it's going through the bone, to be heard in the other ear. This is a surgical procedure. Basically, the surgery just involves elevating the skin here, placing this implant in the bone, and then replacing the skin around it. And this is sort of what it looks like once it's healed, and this is what it looks like wearing the hearing device. Where this is indicated, it's indicated for conductive hearing loss. So for example, a child who is born with an absence of an ear. They have no ear canal and no outer ear, but the inner ear still functions well. Well, one way to get sound into that ear is to transfer it through the bone behind the ear. So conductive hearing loss is one reason where this device significantly helps. And then the other reason for which it is marketed is single-sided hearing loss. And again, as we mentioned, that's transferring sound to the other ear. And so this diagram depicts how the device works. Again, this implant is a titanium screw that goes into the skull. Titanium is very well tolerated in the body, and that's why hip joints, knee joints, all these different things are made of titanium, is because it doesn't induce much of a reaction and it doesn't get rejected by the body. The other important thing is that bone will actually integrate with titanium. So the surrounding bone cells will attach to titanium and adhere to it, and it becomes very strongly fixed in place. And so this screw is actually going into the bone, but then the abutment comes through the skin, and here's where the hearing aid is attached. Sound vibrations travel through the bone of the skull to the inner ear on the same side, if this ear is working, and that would be a case where you can't use the ear canal, for example. In addition to that, sound will travel all the way through the skull to the opposite ear, and this is where it's important for someone who has a single-sided deafness. So in a situation where you've completely lost all the hearing in one ear, where the inner ear nerve function is completely gone, this device can be placed on that side, and the sound will be carried over to the other ear. Now again, it's not perfect. You're not utilizing that ear to hear. You're still hearing it in the other side, but it's a means of being able to detect sounds coming from the right side of the body, if that's the side where the hearing loss is. this is the, again, the fitting range. So as long as you have hearing, at least down to 50 or 60 decibels, the hearing aid is strong enough to be able to amplify and overcome this hearing loss here. If your hearing loss is greater than about 60 decibels, they don't have a device strong enough to amplify sounds to overcome that. Along similar lines, there's a new technology known as the soundbite that has come out called Sonitus Medical. And again, it's indicated for the same types of hearing loss, either a conductive hearing loss or someone who has a deaf ear on just one side. Rather than using the skull to send the sound through the bone, it actually uses your teeth. And it's always been known that teeth are excellent conductors of sound. And oftentimes we'll do a test in the clinic where we take a tuning fork and we'll place it on the tooth to see which ear it will sound loudest in. And so this device places a small transducer on the molar teeth and transfers sound through the teeth. It was FDA approved in January of 2011. The components of this, you do have to wear a behind-the-ear sound processor and receiver. This microphone sits down in the ear canal. Again, it has the feature that it uses the normal ear canal to detect sounds. The sound is then transferred through this, into this sound processor where it's amplified, and then wirelessly the sound is sent to this transducer here. And this is what clips onto the molar teeth, and you can see this is kind of what it looks like on a model here, and then in a real person. So obviously one of the things you have to have for this to work is you have to have pretty good molar teeth back here to have something for it to attach to. Now obviously when seeing this, the question comes about is what about eating and things like that? You can eat with this in place. A lot of patients prefer to take it out during meals just because with a lot of chewing and stuff you do pick up a little bit of sound from that. But it's perfectly fine to do that. They provide a kit to clean it with or to soak it with afterwards. It comes with this battery charger, so for both the behind-the-ear receiver and the actual transducer, it has a built-in battery that's rechargeable, so you're not having to change out batteries all the time. For the behind-the-ear receiver, the battery will last about 15 to 18 hours before it has to be recharged. For the in-the-mouth transducer, it lasts about 6 to 8 hours. And so, again, the way this works, this is having it be placed. It does require, we have a dentist who works with us who has to take an impression of the molar teeth, and then they send that impression off to have the actual device fitted and made properly. And then you just clip it right on like a retainer onto the molar teeth. And this is sort of, when someone's wearing it, unless you have a really wide smile, you really wouldn't be able to tell that they were wearing something. But the portion that's clipped onto the molar will vibrate the tooth and the bone around the tooth, and then once that sound is vibrating the bone, it travels through the bone to actually both inner ears. If it's a situation where the right ear, and when we look at these pictures looking head on, this is always the right side, if this ear is dead and not working, you would wear the sound processor or receiver on the right ear and place the appliance closest to it on the right side. Sound would then travel through the bone to your good ear. And so again, it's a means of allowing you to pick up sounds coming from the right side or whichever side you have the hearing loss on. The nice thing about this is it's relatively simple. It's non-surgical, it's non-invasive, it's removable. The sound quality is very good because it takes advantage of the normal acoustic properties of the ear canal and doesn't block the whole ear canal. You do get a much wider frequency response, meaning that you can hear well over a much wider frequency range, from about 500 to 12,000. It's fairly discreet. I think if anything, some people don't like the idea of having some appliance in their mouth. But the hearing aid portion behind the ear is very small and discreet. It has a very good safety profile. So far, there's been no evidence that it changes the condition of the teeth, and the treatment cost is lower. Now, currently, if you're interested in this, there is an upfront cost. However, Sonitus actually will then bill take over with the paperwork with submitting it to your insurance company, and according to them, in the majority of patients, insurance has covered this. So. If it's something you were interested in, we do a consult, and they actually have a representative from Sonatus come out to discuss it with you further and to talk about the whole treatment course. And then finally, I'll briefly mention cochlear implants. This is the one device that really probably has truly revolutionized hearing loss. And it's actually, it's not that new. It first was developed, the technology was sort of developed in the 60s, but the first devices came out in the 70s. And this is for someone who is profoundly deaf, who loses completely all their hearing in both ears and is unable to use any type of hearing device. And so in order to be a candidate for this, because I often see patients who come in and they're interested in cochlear implants, there are two things. One, you have to be nearly completely deaf, and you have to be deaf in both ears. So if you have good hearing in one ear, but you're deaf in the other ear, you're not a candidate. And so this is the hearing loss range we're talking about. Even at a level of 90 to 120 decibels, you still can't hear things. The other thing that's important is the speech discrimination. So you may have hearing loss in the severe hearing range, or even moderately severe, but if your understanding score is below 50%, you may still be a candidate for one of these. And this is a cochlea. Again, we've seen these pictures. You can see the nerve here, and then there's big absence of nerves in this region, and in this region, and then here, and here. And so this individual would obviously have significant difficulties with their hearing. The way this device works is an active electrode is placed into the cochlea itself, and this is, again, a histologic section, and this is showing what this electrode looks like, and it's placed into the cochlea and actually feeds around the turns of the cochlea. What it's doing is actually bypassing those little hair cells, or the actual sensory nerves, and it's directly stimulating the hearing nerve itself, the main trunk of the hearing nerve. And so it's able to bring back hearing to someone who has become completely deaf. Currently, there are 3 manufacturers, Advanced Bionics Corporation, Cochlear Corporation, Med-El Corporation. Patients often ask which is the best. As far as hearing results, the hearing is equal with all 3 companies. There are small features that are offered by the different devices that some patients may select one over the other. The other thing to mention is that if someone was born deaf and they've never heard their whole life, and then as an adult they want to have a cochlear implant, they are not good candidates, because you have to have had some hearing between the age of about 2 to 4 years in order for the brain to develop the hearing parts that it needs to understand sound. And so if you've never heard sound since birth and you get a cochlear implant, no matter how you program it, it just sounds like gibberish. You can't make sense of anything you're hearing. And so one of the criteria for implanting patients is they have to have developed speech, and they have to have had hearing at some point in their life. But there are lots of patients who, at some point, they're teenagers, or 20s, 30s, 40s, they may develop a condition where they lose all of their hearing, and they do extremely well with these devices. In addition, it's been miraculous for young infants who are born deaf, especially inherited types of deafness. If they become implanted around the age of 1, they will develop completely normal speech and go through life as a normal hearing person, which is really quite miraculous. It has drawn some controversy amongst the deaf community, because amongst the deaf community, deafness is not considered a disability, and so they oftentimes are not favorable about children, especially if they have family members born deaf, having cochlear implants. But basically, this is a surgically placed device. As we've seen with all of these implantable devices, you have an actual sound processor here. This portion is placed behind the ear, underneath the skin. The electrode is placed through the mastoid, so an opening in the mastoid has to be created. It goes in behind the eardrum and is actually fed into the cochlea. So it's advanced into the ear and goes around the turns, and it's directly stimulating the hearing nerve here. This is what it actually looks like, and this is a little bit of an older model. They've become, this behind the ear portion is a little bit smaller, but there is a cable with this transducer that sits on top of the sound processor and sits there with a magnet. And so it's not the most inconspicuous thing, but if you are deaf, it's to be able to hear again is pretty wonderful. This is the actual programmer that the patient can use to adjust the volume or to change different listening situations. And then this is some of the different companies, what the devices look like. But again, they all work equally well. This is their hearing before surgery. These arrows mean that there is no measurable response. So even though these sounds were played, the individual cannot hear it. And with the cochlear implant, they're coming back up, pretty close to the normal range. And as far as the clarity of hearing, patients will score anywhere from 80 to 100% correct on their speech tests. Now, one thing to mention about cochlear implants, people always say, well, what does it sound like? And the best way to describe this, if you think of the normal human ear as a piano keyboard with 88 keys, even though in the normal human ear we can hear far more frequencies, but we can hear each one of those 88 keys. But with a cochlear implant, you're only stimulating every 10th key along the length of that keyboard. So you're able to hear low to high frequencies, but you don't get the fine tuning of the normal ear. It doesn't make such a big difference when understanding speech, what someone is saying to you. You can make out words very clearly, but for things like music, obviously it will sound quite different. And that's currently a lot of research is being done to improve that. So it is about a 2-hour surgery. It's considered outpatient surgery, although oftentimes patients will stay overnight for observation. Even though it's implanted, we don't actually turn on the device until about 3 to 4 weeks after surgery. And then there is continued follow-up with the audiologist for programming and any sort of updates with the device. And it's actually something that when it's first turned on, patients, they can hear, but the more you use it, things start to sound more and more natural. And so with that, the future, again, one of the big problems here is insurance. If 80% of the population develops hearing loss at some point in their life, that means they're going to need some sort of treatment. And insurance companies know this, and they don't want to have to cover all those hearing aids and devices. And so it's been quite a struggle with healthcare companies trying to get them to cover hearing loss. But hearing loss is a tremendous disability, and it can be one of the big things as we get older that can prohibit us from leading normal, active lives. And a common thing that happens as you develop hearing loss is you get tired of going to social things because you're tired of asking people to repeat or not being able to hear. And so you start to become more withdrawn. You don't like doing activities as much as you used to. And, from there, things may progress and go downhill. So I think it's a big healthcare problem. It's something that does need to be addressed better. And hopefully, in the future, with changes that we're seeing, perhaps it will get better. Well, thank you very much.